talk that Susan's giving is more or less similar to a talk that she gave to an MIT group some months ago. And when I heard that talk, I thought it was so good that it should be given again to this group. And I asked her if she would, and she graciously agreed to do it. Following the death of her niece in 2008, Susan became a medical detective and a champion promoting genetic testing. She offers continuing medical education seminars and speaks about the importance of genetic testing to lay audiences. So that's what we're going to talk about. Some of the history of how she got into it with her family, and then where this leads, hopefully, the country over the next few years. So, Susan, they're all yours.
All righty. Thanks so much. I'm very happy to have been invited and excited to share my interest in genetic testing with you. So my advocacy for genetic testing prompted me to write a book called The Dressmaker's Mirror: Sudden Death, Genetics, and a Jewish Family Secret. And this has been put out about a year ago by Roman and Littlefield. And one of the reviews from Booklist said that it's part genetics primer and part memoir. And really, it's 25% genetics and 75% family memoir. And the memoir part is to inspire your interest in genetic testing. And in it, I tell of my family's tragedy through the generations, as well as the story of Jewish life in Brooklyn, coming of age as a woman in science, and including my time at MIT. So no healthy young people think they're going to die suddenly. That's something that happens to somebody else, not something we young people, not we, but when we were young and current young people go around worrying about. But I've been struck recently by the fact that sudden death hovered over the 1996 Princeton graduation. I met Celine Grounder at a molecular autopsy roundtable recently, focusing on sudden death, when we discovered that we were both there in 1996 at the Princeton graduation. So the idea with the molecular autopsy is to test people who died suddenly genetically after their death, even if it's 20 years after their death, and then be able to warn their relatives, and to make sure that coroners, when they preserve tissue, don't destroy the DNA. So that was what the meeting we were at was about. But we discovered we were both at the 1996 Princeton graduation. I was there because my son was graduating. Let's see if I can give you I'm sure you can figure out who my son is, but I'll point to him. Because my son was graduating, and Grant Wall was also graduating that day, although we did not know him. I was there with my sister and my niece, so there's me. And Grant was at the prom with his prom date, Celine Gounder, who later became his wife. And she also became a physician and a medical journalist. So this picture of my sister, she was 54 years old, and it was just a few years before her prolonged illness. When she got sick, she was a kindergarten teacher, and she was coughing and out of breath. And, her doc told her, "Oh, you've got a cold." And then still didn't go away. She said, "Oh, must be bronchitis. Oh, I guess it's pneumonia." Gave her more and more antibiotics. They were into antibiotics in those days. And eventually, I was on the phone with my sister all the time. This seemed ridiculous. I told my nephew, who was living in Boston, out where you guys are, his wife was a resident out there, that something didn't seem right. So they got on a plane and they went home to visit my sister, and my niece's wife said, upon looking at my sister dragging herself across the room, "I think it's heart failure." And indeed, visit to a cardiologist confirmed the diagnosis of heart failure. All of this bronchitis and pneumonia, that wasn't bronchitis, it wasn't pneumonia, it was all heart failure. And not only did they diagnose heart failure, but they diagnosed dilated cardiomyopathy, DCM. And after they took a family history, there was no cardiomyopathy in our family as far as we knew. And she didn't have diabetes, and she wasn't a drug addict. She wasn't alcoholic. There was no cause that they could come up with. So they said that a virus caused it, that this was the long-term effects of some, flu virus that she didn't even notice, but that caused this disease. So that was what we were told. Here's a picture of Grant Wald, 26 years after his Princeton graduation. And this was right before his sudden death. And he died while covering the World Cup of soccer in Qatar. Some of you may remember that incident. It was a big deal over the news. And this is my niece, Karen, 13 years after the graduation. And in the intervening time, Karen traveled the world. She became fluent in French. She married actually twice. And so her first marriage ended in a short divorce. Then she reconnected with her high school friend, Andrew. They had a whirlwind romance, and they were soon married, and they were thrilled that despite her being 36, she got pregnant right away. And here they are on top of the world, showing off her bump. Karen had complained of getting out of breath to her doctors, and they told her that all women who are 6 months pregnant get out of breath climbing stairs. This is no problem. So the day after this picture was taken, Karen and Andrew were walking around in downtown Brooklyn, and they stopped in at a little restaurant. They ate a little bit of food, not a whole meal. And as they were leaving, she filled out a card saying, this restaurant's a 10. It's a great restaurant. And she collapsed in her chair. And they called an ambulance, and they were unable to restart her heart. And they took her to the hospital, but both she and the baby were dead. The initial autopsy report, they found no problems that they could, this time they were really looking for drugs or murder or something, and they couldn't find anything. But they were smart enough to take her heart and send that away for further study. And a couple of weeks later, the diagnosis came back, dilated cardiomyopathy, DCM, the same disease that my sister had been diagnosed with. So as a geneticist, I figured out this probably wasn't caused by a virus. It was probably genetic. And I went into panic mode because my daughter was also pregnant at the time. And I was wanted very much to find out what the mutation was. So both Karen's sudden death and Grant Wald's sudden death were caused by hidden mutations, and neither of them had suspected anything from family history. So my sister's DCM followed my niece's sudden death, and it made us realize that a virus didn't cause it. It was probably a genetic cause. And eventually I came to realize that it came from my father's side. My father had come to visit us, me and Skokie, and when my husband was away learning a programming language. Back then, he went off to learn a programming language for his work. My parents came to help me out with the kids, and we were in a pancake house. And my dad says to me, I think I better go home. I don't feel well. I said, should we go to a hospital? Should we go home? No, just go home. On the way home, he says, maybe you should go to a hospital. Well, I was a minute from the house, so I went in, I ran in, I called them, and they took him to the hospital, but he died before I got there. And the doctor said that this was a coroner's case and that they should do an autopsy. My mother thought, well, she knows that there was no foul play here, and she wasn't very religious, but she knew that you weren't supposed to mutilate the body according to the Jewish religion. And so she said, I don't want an autopsy. It's against my religion. And so the doctor just said, okay, fine, you don't want it, that's fine. He didn't explain that it might have saved a life. In that case, it would trump anything according to the Jewish religion, and you do anything to save a life except take a life. So that's another family person. Then many years earlier, my father's brother, who at the age of 4 died suddenly. He died, according to family lore, when his mother's huge dressmaker's mirror fell on him and killed him. Remember those huge, very heavy mirrors they had in those days, floor to ceiling mirrors. And I'll come back to his story later. But for now, here's a picture of his mother, the dressmaker, my father's mother as well. And she died in her sleep when she was 59. Again, no autopsy. They just said heart attack. My father's death was also said to be heart attack. So the purpose of the talk today and the purpose of my book is to try to prevent tragedies like these by promoting genetic testing and screening. So now that I hope I've captured your attention and your heart, let's look at the problem I'm here to discuss. A recent Becker's Hospital review asks, cardiogenomic testing is a must for certain genetic patients. So why is adoption by cardiologists so low? So to answer this, first let's look at when genetic testing is currently recommended for heart disease. So it's recommended for patients who have cardiomyopathy, even if there's no family history. Anybody who has cardiomyopathy, whether it be DCM, HCM, or ACM, unless it's caused by coronary artery disease, any of these patients should get genetic testing according to the current guidelines. Anybody who has channelopathies, long QT syndrome, Brugada syndrome, short QT, CPVT, all of these patients should get genetic testing. Anyone with aortopathies, Marfan syndrome, for example, which is what killed Grant Wall, or family lipidemias should be tested genetically. That's all, even if there's no family history. And certainly if there's a family history of heart disease, there should be genetic testing. That is the recommendation. So how are we doing? Okay. People with long QT syndrome, instead of 100% of them being tested, currently 1.2%. People with DCM, cardiomyopathy, not testing 100%. We're testing less than 1% of them. What is wrong? Why are we testing so few people despite the guidelines? And it seems that a big part of the problem is myths. So let's try to dispel some of these myths. One of the myths is that genetic testing costs thousands of dollars. And it is true that the first sequencing of the whole genome cost $1 billion. But that was a long time ago, and things have changed a lot now. Now you can sequence a whole genome for, on sale, less than 500. But we don't need to sequence the whole genome. You can sequence portions of it, and most patients pay less than $100. And often the out-of-pocket maximum for the patient is $250 or less. This is comparable to, or less than, many genetic tests and many health tests that we undergo all the time and don't think twice about. There's a myth that ordering and interpreting the genetic test is very complicated. Well, if you go on the websites, it's about as complicated as buying a dress or a tie online from Macy's. It's not easy. You got to figure it out, the website, but it's no harder than that. And it can be interpreted easily with company provided genetic counselors. So a lot of physicians are still frightened of genetics. They don't want to deal with it. They're afraid they're going to have to interpret everything. They don't. There are genetic counselors whose job it is who will interpret it. All the physician or healthcare provider has to do is order the test. Myth: sudden cardiac arrest only occurs to those with a known heart issue. That's not true. Sudden cardiac arrest is often the first symptom of a heart problem. So if we wait to get a symptom, it's too late. Sudden cardiac arrest only happens to old people, and they don't count. No, genetic heart conditions can affect people of all ages. Learning about a genetic mutation just causes worry. Why do it? There's nothing we can do about it. Actually, learning about many mutations can lead to action that can save and improve lives. So I'd like to pause here and make a pitch for dealing with genetic testing. People are often afraid of it. Please consider it something like getting your blood pressure measured, finding out if you have high cholesterol. These are things that give you a clue as to your health and give you a chance to improve your health. Just because you have high blood pressure doesn't mean you're going to die immediately of high blood pressure. Just because they find a mutation that could cause disease doesn't mean that you're going to die of this mutation. It's a warning for you to prevent that mutation from causing you ill health. So often, in the case of the mutation that affects my family, the thing you can do about it, if things get worse and worse, and if they find a problem, one of the things you can do is have an implanted defibrillator. And people are often, they don't even want to think of the possibility that they would have to put a defibrillator in a 20-year-old, a child of theirs. These are people who haven't suffered the death of a child. Having a defibrillator inserted is nothing compared to having a dead kid. Okay, so certainly bad genes aren't the only cause of heart disease. It often does result from environmental factors. It can result from a virus, pregnancy, obesity, smoking, diabetes, drugs, alcohol. But now we know that there are over 100 genes that can cause disease. And furthermore, we know that the combination of environmental factors and genes make it even more likely to have heart disease. So this partially explains why some people in a family with the same genes, some of them get sick, they may be doing drugs, and some of them don't. They may be living a healthy lifestyle. But the important thing to know is that it used to be that physicians would say, well, if we know the cause, if there's an environmental cause, there's no point doing genetic testing. But that's not true, because we now know that 1 in 5 people who have heart disease and also have an environmental cause, 1 in 5 of them also have a mutation that is contributing to the heart disease. And by finding the mutation, it often doesn't do much for the person who's sick. You already know that person has cardiomyopathy, you're already treating them. What it does do is it alerts the family members to get tested and can sometimes prevent them from sudden death and certainly early treatment of heart disease. And as I mentioned beforehand, I don't know how many of you were online then, a recent report, a recent change in recommendations is that all cancer survivors, and this is a list of the huge numbers of cancer survivors we have in this country, all cancer survivors should get a genetic test. It's not going to help them. They already had cancer and survived it. It's going to help their relatives if they had, and 13% of them have a mutation that likely caused their cancer. 13%. So if they have that mutation, maybe their children, their sisters, or brothers, cousins also have the mutation, and they haven't had cancer yet. Now they can be on the lookout for it and get tested sooner. Okay, so this slide describes the different genetic bases for heart disease. It's sometimes caused by a single gene, we call this monogenic, and this one gene has a big effect causing the disease. In other cases, mutations in just a few genes are required to cause the disease, and those are called oligogenetic. And in other cases, even more genes, lots of genes, are required to interact to cause disease, and these are called polygenic. And currently, the most well-characterized effects are mutations in a single gene. We call these the monogenic, and these are the ones that we're going to be talking about that we know the most about. But they're much more prevalent than you might think. So about 1 in 500 people in the United States have heterotropic cardiomyopathy, and 1 in 250 people have dilated cardiomyopathy. And among these patients, whether they know they have this or not, about 50% of them are genetic. That's a lot of people who have mutations causing disease. And we know if a patient has this mutation, proactive treatment can prevent sudden death, which is often the first symptom of disease. So people have cardiomyopathy, they don't know they have it. They have no symptoms, they don't notice it. If they get heart failure, they notice it, but cardiomyopathy, they don't notice. But there are drugs that can reduce the effect of cardiomyopathy, and they can be clinically treated, which will lower the chance of the disease getting worse and causing death. Okay, so now I'm going to do a little quick review on how monogenic mutations can cause disease. So first, let me remind you that the sequence in DNA, a section of DNA, is a gene, and that is something that codes for a protein. It codes through it through RNA and then translated to protein. But basically, the sequence of the bases, the A, C, G, and T bases, is a code for the protein. And we always get one copy of a gene from our father and one copy from our mother. And if we get a good copy from both of them, then we make a lot of good protein from the father's gene and a lot of good of that same protein from the mother's gene. Now, these may have slight differences, the sequences, but they're not important. They just make the protein a little tiny different or not even different. But every now and then, of course, there are mutations. And sometimes there's a mutation that is so bad that it knocks out the function of this protein. Either the protein's not made at all, or it's made, but it doesn't work. And if you inherit one bad copy from your mother, if having half of the protein encoded from your father is good enough, half the protein's okay, then it's a recessive mutation and you're fine. I'm going to be talking, then you would have to have had 2 bad mutations to knock out the protein. But I'm going to be talking about dominant mutations where knocking out half the protein is enough to make you sick. So this is the kinds of mutations that cause a lot of disease. Recessive mutations, by the way, counseling for recessive mutations for expectant parents is in a much better shape than looking for dominant mutations that cause disease. So because you find a mutation, I told you that there are changes, just changes that cause no problem. How do we know if this is a bad mutation or not, if it's something we need to worry about? Well, this is something that the genetic counselors are going to tell you the best that they know. So what we know is that they will classify all the different kinds of mutations in a gene or variations in a gene, and they come up with these classifications. Either it's benign, that half the world or 10% of the world has that change and nobody's sick with it. We know that it doesn't cause any problem. Don't worry about it. And on the other end of the spectrum, it's pathogenic. We know very few people have this mutation, and those that have it, the majority of them, many of them get sick. And in between, there's different levels of certainty about whether it will cause disease. So I want to point out that different companies will score genes differently. So the answer that you get when you get a genetic sequence is a snapshot in time. They may change their mind as they get more data. And therefore, that's one of the reasons that repeat testing is useful. Then when we talk about pathogenic mutations, this is a big point I want you to walk home with, is that not all pathogenic mutations will ever cause disease. So you could have the worst mutation and never get sick. It just increases the chance that you will get sick. So follow-up clinical care is essential because you have a much better chance of getting sick, but you might not get sick. It's not, there are a few mutations, Huntington's, but almost all of them are not 100%. So the current challenge in genetic testing is this one in the middle, variant of unknown significance. And so if you're just getting tested because you're curious and you have no disease and you get some variants of unknown significance, the best thing you can do is forget about it for now. If you're getting tested because you have heart disease and you know it's genetic in the family and there's a variant of unknown significance that could cause it, then there's more reason to follow that up carefully. There's a lot of research going on trying to figure out how to categorize variants of unknown significance. And one of them actually uses the organism that I spent my life working on, yeast. And what they do is what they've done is taken very important genes like the BRCA gene that we really want to know if a variant is pathogenic or not. And they've made all the possible changes in that gene, and they've put them into the model organism yeast, where they can test if the protein is made or not. And then they can tell you the protein wasn't made. It's a bad variant. So that's going to take a long time to do it that way. I think with AI, we may get there faster. So summarize what I've told you so far. Genetic testing can help your health because it can help you detect disease early. But detecting disease, it'll only help you detect disease early if you follow up with clinical testing. So for example, in my family, if you were tested and found that you had the FLNC mutation in FLNC, you'd have to get frequent echocardiograms, MRIs, not frequent, but every year, MRIs, a Holter monitor for arrhythmia, and you'd have to be willing to take drugs for cardiomyopathy. And if things got worse, you might need an implanted defibrillator or even a heart transplant. Again, this sounds overwhelming, but it's really not overwhelming. I know people who live great lives with a heart transplant, and they would have been dead. So yeah, it can also direct therapy, as somebody was pointing out. Wife had pancreatic cancer, and certain mutations would dictate one course of therapy, and other mutations, a different course of therapy. One of the very important things about getting genetic testing is not to protect the patient. We already know the patient is sick. We already have some idea as to how to treat them. The critical thing is to protect family members that carry the disease-causing mutation and have no idea that they're at risk, so that they can get early treatment. Another thing that's happened lately is for expectant parents, people who know they have the mutation and don't want to pass it on to their children. So rather than do genetic testing on the fetus and do abortions, there's a new procedure called pre-implantation genetic testing, PGT. And what they do is they have an in vitro fertilization and let the embryo grow in vitro for 5 or 6 days. And it grows to about 100 or 200 cell embryo. And if they take 4 to 6 cells out of that embryo, it doesn't cause any problem, they can test it. And if the mutation is there, they don't implant that embryo. If the mutation isn't there, they can implant that embryo. And that's often much less upsetting than going through a case where you kill a baby. You have, yeah. Okay, I'll move on. I've lost that word. So we have a lot of genes. There are 25,000 genes in the human genome, approximately, and 7,000 of them are believed to cause disease when mutated. But we're focusing right now, 84 of them are what we call actionable. And we're going to get more and more actionable genes as time goes on. But these genes are said to be actionable because you can do something. If you find out you have a mutation in these genes, you can do something to intervene and make a difference. So you can either cure the disease or prevent bad things happening from the disease and improve the quality of life. So the American College of Medical Genetics and Genomics has committees to debate, is a gene actionable? And they've come up this year, every year they add a few genes, and sometimes they take a gene away. They have a list of 84 genes that they consider actionable. Now, different organizations consider different genes actionable, different numbers. ClinGen considers more like 140 genes to be actionable. So an example of a gene that's not actionable would be Huntington's disease. There's nothing you can do except pre-implantation genetics if you want to have kids, but there's nothing you can do currently to prevent Huntington's disease or make things better. So what the American College of Medical Genetics and Genomics says is that if you get genetic testing for some reasons, so say you're checking for cancer genes, and by chance you find a gene that doesn't cause cancer, but that's in one of these 84 actionable genes, your doctor should tell you about it. You should be alerted to that possibility. But what they don't say is that you should go out and get tested for all of these 84 genes and find out if you have a mutation. And I'll discuss later, this seems like a disconnect, a little later in the talk, I'll discuss why they might be saying that and my thoughts on that issue. I do want to point out that if you want to contact the American College of Medical Genomics and suggest that a gene be considered for their panel of 80 of actionable genes, they take recommendations from the public, especially from people who have a family problem or medical people. And they will also debate or take things off the list. So people sometimes write in and say, I'm sorry I learned I had this mutation. There was nothing I could do about it. Take it off the list. Okay, so by focusing on actionable genes, we hope to avoid conversations like this. Here's the patient. The doctor's just told him he has a mutation in such and such a gene. Patient says, what should I do? What should I do about it? And the doc has nothing to say except, you should have chosen parents with better genes. So here's a list of actionable genes. We're not going to go through them, but just to tell you that there's genes that can cause hereditary cancer, cardiovascular genes, genes in areas of metabolism, and a variety of other genes. So let's look at some actionable genes that increase cancer risk. The name of the gene here is written, APC is the gene, CDH1 is the gene, BRCA1 is the gene that many of you have heard of. If you don't have these genes, the chance that you get colorectal, stomach, breast cancer is indicated by the sort of yellow color. If you do have a mutation in the gene indicated, your chance of getting the disease goes way up. Okay, it's not 100%. It's just much increased. So people with these mutations, so BRCA here is causing both breast cancer and ovarian cancer. This is the cancer risk among women, but these mutations also affect men. Even BRCA affects men. So if you have early detection of breast cancer, the survival rate is 98%. If it's caught when it's advanced, it's only 25%. If you have early detection for colorectal cancer, it's 90% survival. When caught at an advanced stage, it's only 13%. So again, clinical, being warned because you have the mutation to get more frequent clinical tests is essential. It doesn't help to know you have the mutation if you don't get the increased clinical tests. Same kind of chart for mutations that cause heart disease. These are the mutations. This is the chance of, what do I got here? DCM. Okay, the chance of dilated cardiomyopathy if you have a mutation goes up. If you have heterotropic cardiomyopathy, if you have a mutation goes up. The average risks with these mutations is huge of heart disease, much less without the mutations. So sometimes, despite a family history of disease, no mutation is found. And that's actually what happened in my family. My sister and my niece had the mutation, and when we went to the genetic cardiologist that I knew in Chicago, I knew her husband because he was a yeast geneticist. She sent it out to the fledgling genetic testing that was available at the time, and no, it wasn't one of the mutations that caused heart disease. So why is it that no mutation might be found even today, even though we know it's genetic? Does anybody want to call out and give me an answer? Why do you think that might be?
Hasn't been discovered yet.
Good choice. So the mutation could be in an unknown gene, or it could be polygenic. So what do we do if nothing's found? Well, you better test again in a year or two, because we're finding a lot of new genes all the time. And while you're waiting, what should you do?
Get checked.
Treat it as if you have the mutation. Do clinical screens for first and second degree relatives. Just assume you've got it. So you're getting clinical screens while you're waiting, and you're testing again in a year or two. So family history can be very misleading. And the reason is that even if you have the mutation, you may never show the disease. So it's hard to follow the history. And so I want to teach you, this is the stuff that I really want to teach you. The most important thing is penetrance. Penetrance is the chance that the mutation causes an effect. Expressivity is the level of effect caused by the mutation. Let me go back. That reminds me, I wanted to show you something here. Okay, this chart here that I drew for FLNC is a little misleading. So the FLNC gene is the one that causes sudden death and cardiomyopathy, and that affected my family. 90% of the people who have that mutation do not die of sudden death. 90% of the people who have that mutation, if they go to their doctor and they get tested for heart disease, the doctor will find an abnormality. Most of those people can live normal lives and never know they had the mutation. 15% will die of sudden death. So that's a difference in expressivity. Some of them die sudden death, some of them don't even notice they have the mutation. That's a difference, yes, in expressivity. Penetrance is that 90% of them have some kind of effect, and 10% is not penetrant at all. Okay. So I want to give a human face to penetrance and family history. First, I want to tell you the story of my family and my son, Michael. I told you that we knew that it was likely genetic because it affected my sister and my niece, but we couldn't find the mutation. And so the doctor told us to do what we figured out, act as if we have the mutation and get tested every year with an echocardiogram. So I wanted to tell my children, who were adults by then in their 30s, that this has happened and they need to get an echocardiogram every year. Well, my husband didn't want me to tell them. He was afraid. You tell them this, they won't have kids. Where are those grandchildren I want? my daughter was pregnant, but maybe she won't have another kid, and maybe Mike won't have kids. And no, if this was a fluke, it's never going to happen again. Don't tell them. Well, I felt I had to tell them. This was very, critical. So we came to a compromise. The compromise was I could tell them. I could tell them everything the doctor told me, anything I wanted to tell them, but I could only tell them once. I couldn't ask them in 2 months, did you get that echocardiogram? What was the result? I couldn't ask them the next year, do you remember to get that echocardiogram? That was out of bounds. They were old enough, they'd heard the information. Don't frighten them again and again, ask once. So I agreed to that. That's what we did. And about 8 years after I told them, first of all, I knew my daughter was getting checked all the time. She was always worried about it. She was telling me about it. I never heard of anything back from my son. And about 8 years later, when we discovered that I did not have the mutation, I told them, you don't have to get tested anymore. It's over. I don't have the mutation. You can't have the mutation. And my son said to me, my daughter said, oh, thank goodness. I'm so glad, I don't have to worry about this. My son said, tested? Tested? Was I supposed to be getting tested for something? I said, yes, I told you about this, Karen's mutation. And he said, oh, I went to my doctor and I told my doctor that you said that I should get an echocardiogram every year. And the doctor said, does your mother have cardiomyopathy? And I said, no, my mother's fine. She doesn't have any heart disease. So the doctor said, if your mother doesn't have heart disease, you can't get heart disease. And what was wrong with that? The doctor didn't know about penetrance. Might have gotten heart disease next year. I might never have gotten heart disease, but I could have had the mutation, and I could have given the mutation to my son. That's the one thing you got to walk out of, knowing that having the mutation doesn't mean that you're going to get sick, and it doesn't mean that you can't pass on the propensity for getting sick to your children. Okay, and the other story I wanted to tell you about was a story of my father's brother. I knew from family lore, my father knew what killed his brother was this huge dressmaker's mirror falling on him. My uncle knew this story, my cousins knew this story, and it haunted us. Well, when I wrote the book about my family and about genetic testing, I looked up the death certificate to see what kind of injuries did he have, and how did this kill him? And I was shocked to find that there were no injuries. The child died of congestive heart failure. It was a total lie. All these, the whole story was a lie. There were newspaper articles at the time describing his heart disease, and that he was in the hospital for 5 days with heart failure, and his subsequent death in the hospital. I believe that even then, my grandparents didn't know about DNA, but they knew about genetics. They must have known that there was something else in the family as well. They moved from the town they were in, where they had a business and everything, friends. They moved where people didn't know about it. And they came up with this story, and they were trying to protect my father, and later his younger brother, who was born later, from being discriminated against because of this disease in the family. And indeed, my mother's mother was on the lookout for things like that, and my parents would never have married if she had known about this in the family. But we didn't know about family history, and knowing that family history could have saved my niece. Okay, so because family history can be so tricky, and because of penetrance can hide disease, in my view, we shouldn't rely on it, but we should instead fund universal screening. So the case for universal screening is that 1 in 2 people with the BRCA mutation have no breast cancer family history. 1 in 5 people without a family history have genetic disease. 1 in 6 people who get tested will have an actionable change in care. There's more than 50 known hereditary cancer syndromes, and 1 in 250 people have hereditary heart problems. So let's compare that to things that we do test for in newborns. 1 in 2,500 newborns have congenital hypothyroidism, and we test for that. 1 in 53,000 newborns have galactosemia, and we test for that. So in my view, we should be testing in all adults for these mutations. So why is it that I'm suggesting that we should be testing for these 84 genes that are actionable. And this can be done, it should be confidential, like any of your medical history is confidential. If somebody breaks into your doctor's office and steals your sequence, then I guess people will know about it. But why is it that the American College of Medical Genetics says that you should find out about these? If by chance you find out about them, you should be told, but that you shouldn't go out and get screened? The best I can figure out is they think, 1, it's too expensive to do this for everybody. 2, too few doctors know how to do it. It'll frighten them, and they won't follow up anyway. So what's the point of doing it? There's no follow-up. So if you've already found a doctor who knows about genetic testing and therefore finds out this by accident, they'll probably know how to do it. They'll know how to counsel you, and there'll probably be follow-up there. So for that case, it makes sense. For the other case, it doesn't make sense. To me, that makes no sense. I think we have to educate our doctors and have follow-up care. And it certainly makes no sense for an audience like you, who is very sophisticated and can insist on follow-up care and can insist on understanding the genetics. There is one other concern that is reasonable, and that is if you're testing people who have no disease, it is possible that the mutation that we find in their family and their ethnic group might not cause disease. And that's something to be slightly concerned about. If you did do these tests, which I am going to recommend, because at the end I have a company who will do this for, I think, $295. Insurance won't cover it, but you can do it. It's not prohibitive. If you get a positive result, and if it's something like a disease where they're going to tell you to get an operation and get parts of your body removed, you might want to check into it further and see if people in your family or people in your ethnic group have that disease with that mutation, to make sure that it's doing. If it's something like get an echocardiogram every year, just go ahead and do it. What is actionable? These actionable genes are going to change a lot because we're going to get many better genetic cures. And right now, CRISPR, which is the DNA editing, is going to do a great deal. I forgot to ask you guys, here, let me tell you, I'm on the slide about spinal muscular atrophy. There is a genetic cure for this. If babies are given this injection that carries the good copy of the gene that's not working in their body, that will prevent them from getting this disease. So it's very expensive, but if they can infect the child with the virus that has, instead of the virus DNA, has the good copy of the gene they're missing's DNA, they can prevent the neurological problems that ordinarily occur. It has to be done early before the problems occur. Another way we will be able to prevent and treat disease, you guys are, okay, we talked about this. So if most of the diseases that affect adults are caused by having too little of the protein, what engineering feat could we do to, one thing we said is, as we learn how to edit, we can fix this mutation. If we can't fix this mutation, which is pretty hard, what could we do to prevent disease or make things better?
Add the gene.
Add the gene, that's one approach. And that's the one we talked about. So you'd have an extra copy.
Take it away?
Nope. The other thing you can do is just turn this one up higher. We know how to do that. We can make more from the good gene. And there's small RNAs and various things in the works to enable us to turn on the good gene. So that could help a lot of these dominant mutations. We can turn up the good gene and make good protein. So
Is
what
this
the bad
now
gene
taught in medical schools?
Not really. Medical schools is such a mess. So I don't know. It depends on the medical school. All I can speak about is, I hate to speak badly of my medical school, but University of Nevada, Reno, where I teach very little, like teach for a few hours in the medical school. The way they teach now is medical students don't want lectures. You give them 15 minutes of reading that they're supposed to do. And then you come in and you talk about a specific case, medical case. So we talked about 3 cases. So in the class that I participate in, we talk about someone who's 65 who has cardiomyopathy. I've given them reading that tells them that half the people who have cardiomyopathy need genetic testing, that genetic testing costs less than $250. And so I asked them, with this person who's in their 60s and who has cardiomyopathy, should you recommend a genetic test? And they sit in their little groups and discuss it. And most of the groups decide no, because it's too expensive and the person's too old. I mean, how did they get the fact that it's too expensive? If they did the 15 minutes of reading, they know it's not too expensive. It's only $250. And why would the person be too old? They can save all the children and the relatives. So, I don't know how many people like me are out there trying to preach this, but there's not a lot of the professors who know this. And so it's going to take a long time in some of the medical schools. And that's why I'm trying to get invited to talk. And I talked at UC Stanford, not Stanford, UC Davis. But it's not easy to get invited to talk in, no, I'm going too far, to talk in continuing medical education. They mostly want to talk about, they have to take courses on access, equal care or something. So if anybody of you could get me invited to give a slightly more technical, but not too different from this talk in continuing medical education, I'd love to do that, both for heart disease. In Davis, I spoke to heart disease. In UNR, I spoke generally. Okay, so another example of genetic gene therapy that's been successful is for sickle cell anemia. And in that case, the blood cells, the stem cells, are removed from the patient. First of all, they stimulate the production of stem cells. Then they take out some blood, remove the stem cells, genetically alter them with CRISPR, and treat the patient. It's not easy, but you treat the patient with radiation to kill the stem cells, and then you return the stem cells that have the correct mutation. What does this mutation do? It's a mutation in a gene that ordinarily turns off the synthesis of adult hemoglobin, of fetal hemoglobin. It ordinarily turns off the synthesis of fetal hemoglobin. Well, in these people, the adult hemoglobin isn't working very well. That's why they have sickle cell anemia. So they don't want to turn off the fetal hemoglobin. They want to let it stay on. And that's what this does. They can live nicely with their fetal hemoglobin. Okay, so some take-home messages. Genetic testing can lead to early treatment and protection for the patient and their family. That is, for example, protection from sudden death. But genetic testing is only useful if there's follow-up care, clinical care, for example, more intense screening. Targeted testing is essential if a patient has a disease that is frequently caused by a mutation, or there is a family history of disease. So let me point out, while in the 84 genes that are in the panel of actionable genes, and I'm very proud and happy that the FLNC mutation that affected my family is part of that, and I worked hard to have that happen. If you have cardiomyopathy, there's many more genes that they're going to test you for than that are in that 84, because you have disease. So if you have disease, that's a different thing than if you don't have disease. Family history is often not obvious because of penetrance or misdiagnosis, or they're hiding it. Patients with positive genetic tests are now protected from denial from health insurance. So there's a law protecting you from denial of health insurance, but there's no protections for life insurance or long-term care insurance. So if you're sick, they already know you're sick. Knowing that you have the mutation is not going to affect your insurance. But sometimes people like to get their life insurance or long-term care insurance before getting genetic testing. Okay, so I promised to try to campaign for getting you to get your actionable genes tested. The picturegenetics.com/wellness offers this for $295. This year they have increased from 70 genes up to 80, including almost all. I think they have 83. They're missing one of the actionable genes. You don't need a doctor, or they provide the doctor that you need. All of that's for $295. I don't get any money for this. And you spit in a tube and send it to them, and they have a genetic counselor that will talk with you about it. Obviously, there's no point doing it if you're not going to follow up if you find that you have a mutation. But the other thing is, many of us are a little bit old now, and it's not going to probably affect our lives, but either we can talk our children into doing this. I was successful in doing that. Or if we have mutations, then we can alert our children. So that's something to think about. I also wanted to say that there is now a genetic cardiomyopathy awareness consortium that's been put together in the last year or so. And they are doing the same thing that I try to do in my talk: alert people to the need to get genetic testing, especially for heart disease, and especially if there is cardiomyopathy. So they offer now, they found, actually it's Harvard who offers now free testing for any adult who's diagnosed with cardiomyopathy, or where the doctor thinks it's a genetic cause. And any adult who's previously had genetic testing because of cardiomyopathy, but wants to get updated results, they'll do it for free. So this is the website, geneticcardiomyopathy.org/get-tested. And I also wanted to advertise this connectmyvariant.org organization. They're also just a volunteer organization. And what they do is, if you register your mutation, be it a mutation that caused cancer in your family, or any other disease, or heart disease, they mostly work with cancer, but they're spreading out. They will help you find other people who have that exact same mutation, which will help you. And they have actual professional genealogists who will help you find other relatives to contact. So I think it's a great organization, and trying to contact people to warn them of mutations. Okay, and so then I wanted to play a short
Protect your family
wait, let me
with
stop.
the power of
Let me
genetic
stop
testing.
this.
Siddhartha.
Okay. So I put together a short trailer about my book that I wanted to play. Could you hear it?
Yes.
Yes.
Okay. So I will continue then.
Mukherjee, the author of The Gene, a #1 New York Times bestseller, says, "The Dressmaker's Mirror" by genetics professor Susan
That's my
Liebman
dad in
unfolds
uniform.
as a
My
riveting
dad with me, a
narrative,
painting I did.
tracing the journey from tragedy to
My
triumph
niece
over a
and my
hidden genetic
grandson,
death
my niece who
sentence.
died.
My niece was 36 and pregnant with her first child when suddenly she collapsed and died. I feared a genetic problem and was terrified that my pregnant daughter might also suddenly die. Dr. Elizabeth McNally, a hereditary heart disease expert, took on our case. She found a mutation in a previously unknown heart disease gene, FLNC. My research showed that the mutation is an Ashkenazi Jewish founder mutation. Today, genetic testing can protect families of all ethnicities from a myriad of genetic diseases. But few patients get tested. Let the Dressmaker's Mirror inspire and guide you to protect your family with genetic testing. Discover the Dressmaker's Mirror, Sudden Death, Genetics, and a Jewish Family's Secret. Protect your family with the power of genetic testing. Siddhartha Mukherjee.
Okay. So I mentioned an Ashkenazi founder mutation in that little trailer. So I wanted to tell you what that is. So here's a map of Poland, and in Poland there were lots and lots and lots and lots of Jews a long time ago. And imagine that among the many, many, many Jews, some of them had mutations. For example, that one. Not a high frequency of that mutation, just by chance, because there's so many people. But then came the pogroms, and we're talking 500 years ago, and by the time they were done, there were only about 500 Jews left. And one of them happened to be the one that had the mutation, one of the ones who was still able to have children. And these people married among themselves. And so before too long, there were lots of them again, but a much higher percentage of them have that mutation. That's a founder mutation. It's not just Ashkenazi Jews that have founder mutations. French Canadians who underwent a period of cultural isolation, and the Finnish who were geographically isolated, and other such groups also have founder mutations. So there's nothing, we hear a lot about Ashkenazi mutations. There's nothing about Ashkenazi Jews' DNA that makes them get more mutations. It's this history that causes the appearance of certain mutations, especially recessive mutations because of the intramarriage. So I wanted to share that I am very excited to have gotten some nice publicity for the book, which is also publicity for the mission of promoting genetic testing. Somehow the Daily Mail picked up about my book and wrote an article on it. Hadassah has recently put out a review of the book in Hadassah magazine, and Forward, the online Jewish newspaper, accepted an article that I sent them about the book and published it. And I also wanted to share some things that my niece touched many lives. And I found this on Facebook, on my niece's memory page. And my 6th grade teacher passed away when I was in 7th grade, and it broke my heart. She was one of my favorite teachers, and I was so in shock. I didn't get to say goodbye to her. My mom found this book about her and her family that her aunt wrote, and my mom got it for me. And this is her mom's inscription: "To my princess, I pray these lines bring you closeness, clarity, and closure of sorts. It's like she wanted to be able to help from her current dimension. Love, Mom." And here's another LinkedIn post that I was touched to see by Ana Morales. The first time I learned about her, meaning my niece, was through review of her autopsy report after a sudden tragic death. It is a picture I will never forget, and the reason I have maintained my deep interest in cardiovascular genetics care, especially during pregnancy. Her aunt, Susan Liebman, a genetics scientist, contacted multiple research labs, including the one where I worked as a coordinator. The second time I encountered her story was after I left that research lab to join a new industry-based research collaborations team. Coincidentally, my first assignment in that new job involved working with Susan. So at that time, I thought that this mutation might be the major cause of cardiomyopathy in Ashkenazi Jews. And I thought naively that I could find 50 Ashkenazi Jews with dilated cardiomyopathy, sequence just that tiny region and see how many of them had that mutation. Well, it turns out that very few people who have dilated cardiomyopathy know they have it until they're dead. So I only found 7 such people, and 3 of them had that mutation. Okay, now I see her face again. So, and I had contacted I think it was Invitae to help me with that project. Now I see her face again, Karen Stephanie Rothman-Fried, so beautiful of life with her charming smile on the cover of her Aunt Susan's book, The Dressmaker's Mirror. 16 years later, I find myself reliving her story, my heart pounding as I remember the first time I learned about her, now with a profound layer of reality to that heartbreaking day. A cardiogenetic evaluation can reveal genetic information that can guide prognosis and management. Let's continue sharing stories like this. Cardiovascular genetics is a priority for me, and the Dressmaker's Mirror validates my why. So there you go. I'm
Susan,
open for
thank
questions.
you very, very much. There are a number of questions that have showed up in the chat, and maybe it would be best if you open the chat.
Okay.
Rather than my just trying to read them. But the first one has to do with genetic testing and privacy.
Well, if you get clinical testing, not 23andMe or hereditary. Can you hear me?
Yes, you want to stop sharing?
Oh, yes, I'm sorry.
Thank you.
Okay. So if you get tested by a clinical testing through a physician, well, any kind of clinical testing, not through 23andMe. And I want to point out 23andMe and Ancestry.com, people say, oh, I got tested. That's not testing. That's looking for relatives. That's fun. And it helped me a lot find relatives to warn 23andMe. But it may test, it sequences a tiny, tiny bit of your DNA and tests for very few things. And it's not clinical testing. Clinical testing is protected, just like going to the doctor and finding out you have some disease. That's private. Can genetics be modified if a bad thing is found in your genome? Well, very rarely. We're working on that. So with a genetic cure, it would be turning on the good gene, which we don't really have quite yet. It would be putting in a good gene, which we can do for very few genes, but not for every gene yet, or editing the bad gene with CRISPR, which we're working on. We're getting much closer, and we do have some genetic things that can be done. But very frequently, if you find there's a bad gene, there's clinical things you can do to prevent the disease from having a particularly bad effect on you. So getting testing ahead of time and getting treatment ahead of time is very common. I don't know politics, and I don't know how long that will be. RFK and Trump stopping genetic research. I'm not aware of anything terrible. I did, they're very much trying to promote genetic testing of infants. Certain people and other people are opposed to that. It's, the infant can't give consent. And right now, the biggest thing is infants who seem to have a big medical problem. They want to sequence their full DNA early because they may be able to help them. Sequencing, other people are promoting the idea of sequencing all infants' DNA, complete DNA. That I think was, that hasn't been approved in any way. It's just, an argument. There is some private money going into that. There's also some private money going into rare disease sequencing because of some concern about politics. It never was very well supported, and I don't know where it stands in the politics or how long it'll stand there. Should insurance company refuse to pay for colonoscopy if they see a patient's result of genetic testing shows that they don't have a colorectal cancer gene? No, not at all. We all still have a chance for colorectal cancer. First of all, we don't know all the genes. And second of all, not all of it's caused by genes. Some of it is a random chance. It's just that if you have a gene that can cause colorectal cancer, you shouldn't get tested every 10 years like the rest of us. You should get tested every year. Okay, why should someone get tested again? Does the genome change over time? No. So the reason you should get tested again is if you get your whole genome sequenced, you don't ever need to get your genome sequenced again. And I hope that soon that will be available. And now all you need to do is get it analyzed every few years, because every few years we learn about more genes that can cause disease. The reason for getting tested every few years is because we're not usually sequencing the whole genome. And now they'll sequence you for more genes in the panel for heart disease because they know about more genes. The other reason for getting sequenced again is that you'll get a new analysis of that variant of unknown significance that you had last time that you didn't know what it was. Now this time they'll know. They should be able to do that without resequencing. It isn't quite available yet in a company that I feel comfortable with. You can get your whole genome sequenced. And there is a company, it's very expensive and maybe for a group like this, I should have done it. You yourself have to analyze the results, and you have to buy the ability to analyze the results on the computer. And every year you buy it again and you can analyze and keep track of it. So you don't need to sequence. I think the guy's name is Church, who founded this company. He's got a Nobel Prize in DNA sequencing. And it's a very reputable company. I'm sorry, I don't remember the name. But it's only good for people who are, first of all, have a lot of money. And second of all, are willing to take the responsibility of analyzing the genes themselves and finding out through their website what's changed. What should happen in the next few years is a company that will sequence your full DNA and then will, for a reasonable fee, a few $100s every couple of years, give you the update on the genetic analysis. And I think that's coming.
Do you know whether or not major schools like MIT and others are training an increased number of people in genetics?
I don't think MIT has a genetic counseling group who are the major people who are being trained in genetics. Whether biology has attracted more people because of the revolution, biology revolution, and genetics, probably. So,
the country.
There's a lot of interest in genetics throughout the country, so there should be more. But genetic counseling, unfortunately, it had a great, in the beginning, everybody wanted to be a genetic counselor. It was going to be great. And then it turned out they couldn't find jobs. Right now, it's not so good for genetic counselors. Part of the problem is they insist that a genetic counselor has to be referred to, but a physician has to refer you to a genetic counselor. You can't just go to a genetic counselor. The other thing is the genetic counselor has to be in your state. You can't do it online. So some laws have to change to make it better for genetic counselors. So it's really a labor of love because they're having trouble finding jobs. unfortunately.
Steve, you had a question?
You're muted.
You're
Okay,
muted.
yeah. You're saying that, I think what you're saying is that when you do the genetic testing, it's only testing for, looking for 80 or so factors that are known to cause issues. And that you should get tested again in 2 years or so, because there may be more than 80 that they're looking for, and you'll be able to find out the additional ones at that time.
That's if you're doing just general screening.
Well,
In other
that's
words, you're not sick at all and you're just doing general screening. Yes.
That's the $295. a
Right.
week.
Yeah.
Okay, so if you want to pay umpteen thousands of dollars, the whole thing will be done.
Not umpteen thousand, 500.
Okay, umpteen hundred.
On sale, you can get it for 500. But I'm not comfortable with the analysis by Dante Labs. They don't answer emails. You know, they're going to tell you whether you smile a lot for those for that genome. They're not. The analysis isn't up where I want it yet. Church has a company that might have been 700, but then the next year, if you want to have access to looking for yourself and looking at all the genes yourself, that he has the software to let you do that. And that, I don't know, it costs, $500 a year. I don't remember what it was. It wasn't cheap. It wasn't prohibitive, but it wasn't cheap. And they weren't doing it for you. You had to do it. The last time I looked on this church company.
Susan, with
George Church, yes.
Harvard.
with genetic testing, you can, in fact, keep the information private if you purchase it with cash or check, whatever it is. So there's no audit trail. The results are sent to you personally, and then you can share that with your clinician and therefore take action on it, but it does not become part of your health record and is not available to insurance companies and other people that may impact your financial future, correct?
Yes, you can do that, especially if you do it through an academic sequencing group. They are particularly set up to do that.
So you didn't say anything about academic sequencing groups. How would I find them?
I through a genetic counselor. Some of them like to work with, directly with Harvard or
Mass General and Brigham.
But then when
many of them send that out to a genetic company. I mean, it's supposed to be confidential.
Because I think
they're going to send it to your doctor. They're not going to send it to you.
Right. My wife had breast cancer, and at the time we did genetic counseling for BRCA, as lots of people would. And we did that privately, and therefore the results were never shared because of the privacy issues. We paid for it ourselves, the results came back, and they said that, in her case, she did not have the gene, and therefore we were able to share that with our children. But can you do the same thing here with
you can, and I'm not an expert on that. I'm sorry. I know that you can, and I believe it would be through academic sequencings. That's what I've heard, not through GeneDex or Invitae or these companies that are only going to give the results to your doctor. So,
but the academic sequencing means that the academic institution would have access to your genomes.
Well, somebody's doing the sequencing. Somebody's going to have access. They're telling you it's. They're telling you it's.
If you do it by yourself, the only thing they have is an anonymous reference number, correct? Much like the way they did the screening for diseases.
No, it's not anonymous. As far as I know, it's not anonymous. But they're telling you, not your doctor.
They won't give you the results directly to you. They'll only provide them to a physician because they wanted to be filtered through some interpretive lens so you couldn't, for example, misinterpret the results and do something bad to yourself, and then they would actually have liability. So they're channeling it through a physician, and you have that relationship between you and that physician that you have to provide I think defeats the possibility.
Yeah, so I think that's why the genetic counselors can do this, because they can get the result and get through the academic institution and then give that to you.
So
They're not putting it in your genetic record, the genetic counselor.
So
So I have
that,
a
does that mean if I Google genetic counselors in Massachusetts and find someone, I can contact them directly and then work with them? Is that a possible, is that a scenario?
It's a possibility, yes.
Good,
Yes,
thank you.
Steve.
So my question is, okay, suppose I've seen this and I'm motivated to do something about this. You've mentioned $295, you mentioned $500 for testing, and you mentioned a genetic counselor. How can we find those people? Do we have links to the companies that do these things, or can we get this? Not, maybe not from you, Susan, but
Yeah, I have some in the book, and I can put up a list. I didn't have that for this talk, but I have it on one of my slides from other talks, the talks that I give to doctors, and it sort of changes too. It's changing rapidly.
If you could send that to John or to me,
sure, sure. The only company that I know of that does the 84 genes is the one that I gave you.
Okay. If you could send that information to John.
And that also is not through your doctor, that's through their doctor. So that should be pretty confidential. But yeah, sure. The other things that I know of are going through your doctor has to order it through GeneDex or Precision Genetics or something, and that would go through your doctor and be in your medical record. I have not, don't have a list of what to, of privacy not going through your doctor. The other ways of not going through your doctor, though, is to get the whole genome sequence, like through through George Church's company. That just goes to you. But then you're the one who's interpreting the data. But this group might like that because you're comfortable with the, not too many groups would I recommend that for, but I think this group, that possibility might actually work for you and become a hobby that you could really learn about different genetics, and you might really get into it. So I think that might be the best thing for some of you. It's not that expensive. It's.
Can you talk a little bit about interpreting your own data, what that means? I mean, as of right now, it's a bunch of squiggles on a piece of paper or a bunch of data that I have no idea what I'm looking at.
Yeah. So it's going to give you. I'd have to look and see what it really is going to give you. If it's going to give you whether this new gene is pathogenic, likely pathogenic, or benign, and you just check every year and see if the variant of unknown significance has a different analysis. It'll also give you the actual sequence, which really won't make any sense to you, the actual changes. So the changes in the sequence is never going to change, but every year the analysis of it will change. But there's 25,000 genes.
Right.
So, you have to screen through those. You have to have some way of just finding in the 25,000 which one you want to look for. It's not, an average person is not going to be comfortable looking up FLNC every year in that thing, or some new gene that may have come out. But this group might.
I'm guessing that AI systems over time will be structured in such a way that they can do that kind of research more rapidly.
Absolutely. I think any of these companies could do it more easily and rapidly. I don't know why they're not doing it yet. But this company Dante has sales where they'll sequence your whole genome for like $300 on a sale. But then what do you do with that sequence? Even I can't analyze ATGs and Cs. I'm, been in genetics for 50 years. But so they tell you, oh, you taste, this and such. I mean, I'm not interested in what I can taste. Or I might have an earlobe. And that's not, they're not giving me the analysis that I want. And when they write to them and ask them, what genes are you listing in your cardiomyopathy panel? They'll tell you, you do have heart disease, you don't have heart disease chance. What did you test? Oh, they don't answer me. So I don't know what genes they're analyzing.
Once somebody very wealthy, like a Bill Gates or Altman, has a problem in the family, then all of a sudden the money will flow towards developing a system to automate it.
So let me explain one other thing that I took out of this talk. The difference between a panel of genes. So you have cardiomyopathy and your doctor says, oh, half the people with cardiomyopathy have a mutation. Let's get you tested. And they'll test you for 200 genes that can cause cardiomyopathy. And they'll look at those very carefully. The other thing you can do is you have, and I did this with a relative of mine, has symptoms of ALS, but they claim it's not ALS. We can't figure out what it is. So he gets his whole genome sequenced. And this was from a place that wasn't that cheap. It was several $1,000s. And they analyze it. And what they come up with is no mutations that could cause this effect known. And I say, what mutations did you test? Oh, only the computer knows that. The computer took your analysis and came up with this and such, and we don't know what the computer tested. Well, if I give you 10, if I give you five genes, can you tell me, did they test those genes? Well, okay, maybe we'll try to test, but that doesn't come out in the report. It's like, if you want to get retested, you can get retested or reanalyzed at some point for a fair amount of money. So the panel, you know exactly what you were tested for and if you have a mutation or not. If you get your whole genome sequenced, right now, a lot of these places will not really tell you. You could get good information. They could say, oh, you have, this gene that, and the thing that, I remember was so upsetting was I privately got this relative tested by an academic, and they found a gene that caused a mutation in a gene that caused a disease very similar to the disease he had. And the computer didn't pick it up. So I asked the computer, did they test that gene? And they had tested it, but they decided it wasn't relevant or something. And they got the same answer. So it wasn't a mistake in the sequencing. So I'm not thrilled with the whole genome yet analysis, because they're not set up to give
genetic testing that makes it difficult to analyze for a person. A computer can look at hundreds of genes, and certain combinations are what the problem. It's not that it's present or absent, but rather certain combinations. And it's too onerous for an individual to do it, on a piece of paper.
The computers can't even do that yet. So they're working on that. That's the polygenic.
Yeah.
And there are some computer programs that are doing that, but that's just not widespread yet. So, polygenic that's causing schizophrenia. There's schizophrenia in the family. There's not one gene. It's an array of genes, and they can give you sometimes some kind of level of chance for your array of genes. And that would require whole gene sequencing and knowledge of that particular disease. And that's very much in its infancy.